Let's do psych. So, depression. There are two questions to screen for depression. We're mainly looking for the two main symptoms of depression, which is depressed mood, so feeling down, depressed, or hopeless, and diminished interest or pleasure, so little interest or pleasure in doing things. So these are the two main symptoms of depression, and these are one of these at least has to be present in order to diagnose depression. Like if the answer to both of these is no, then we cannot diagnose depression. Sorry, yeah, you cannot diagnose depression. So at least one has to be positive. So if they said yes to either, we do a full assessment using either a patient health questionnaire or a hospital anxiety and depression scale. There are 9 items, which are the DSM criteria for MDD. We remember them by D, SIG, E, CAPS. So depressed mood, sleep problems, either insomnia or hypersomnia or early morning awakening. I, diminished interest or pleasure. E for nothing actually. Oh, E is for loss of. Oh, sorry. SIG. G is for guilt. E is for loss of energy. C is for reduced concentration. A is for appetite changes, either significant weight gain or weight loss without dieting. P is psychomotor agitation or retardation. And finally, S is suicidal ideation or attempt. Now, severity. If it's mild, 5 or a few more plus minor functional impairment is mild, and most of the 9 plus significant functional impairment is severe. Moderate is in between. There is another type, which is psychotic depression. It's uncommon, but it has a high risk of suicide. How to differentiate from schizophrenia is that the low mood is before the psychotic symptoms appear, and the delusions and the hallucinations are mood congruent, meaning that they are depressive. Okay. Depression in the elderly are less likely to complain of depressed mood. They're more likely to complain of physical symptoms, agitation, global memory loss, and this is called depressive pseudodementia. The main way to differentiate between pseudodementia, depressive pseudodementia, and actual dementia in geriatric population is by looking at their memory loss. Is it global or is it only for recent memory? If it's global, it's more likely to be depression. Biological symptoms and reluctant to take tests and being disappointed with the results, unlike dementia. First line for depression in the elderly is SSRIs. Let's try to remember what SSRI I think it was citalopram. Let me check. Yeah, it's most probably citalopram. Yeah, that's what depression with Alzheimer's in the elderly. Yeah, okay. Let's compare the 3 Ds: delirium, depression, and dementia. Delirium is hours to days, dementia is months to years, depression is weeks to months. Delirium is reversible with treatment. It usually lasts less than a month. Dementia is progressive and fatal. It lasts years to decades. Depression is chronic, but it responds to treatment. Duration is months. Orientation. Delirium delirium would be impaired orientation. Dementia and depression would be intact. However, dementia would lose orientation to time, then place, then person. So it starts with time and then place, and the last thing would be to person. Next is consciousness. So attention and consciousness. So attention would be impaired in delirium, and consciousness would also be impaired, but it would be intact in dementia and depression. Now, for suicide, there are some risk factors. Male sex has a hazard ratio of 2, advancing age, depression. Schizophrenia is high risk for suicide. 10% of people with schizophrenia will go on to complete suicide. Alcohol or drug misuse, history of deliberate self-harm, that's more than alcohol. History of mental illness, chronic disease, unemployment, social isolation, being unmarried, living alone. Risk factor for second attempts is when there is an effort to avoid discovery, planning, leaving a written note, sorting out finances, or a violent method of suicide. Protective factors are family support, having children at home, and religious belief. In the second week after starting as an SSRI, that's when the greatest risk for suicide is, so we have to monitor the patient. Management. There is a duty under common law to restrain the patient. Remain the patient with the patient at all times and restrain the patient until the on-duty psychiatrist arrives. Okay, seasonal affective disorder occurs around winter related to melatonin. There would be symptoms of hyperphagia, hypersomnia, and weight gain. The treatment would be psychological therapy, bright light therapy. Do not give sleeping tablets. Bipolar disorder, sorry. I don't know what I'm doing. So there are different types. So bipolar 1, it's it's mania, mania and depression. It would start with depression for 2 weeks, and then bipolar, and then mania. Mania lasts at least a week. Bipolar 2 also starts with depression for 2 weeks, but there would be hypomania. Hypomania, we're going to differentiate between hypomania and mania now, but both of them are episodic and recurrent between alterations between depression and mania or hypomania. This is kind of irritating me. The order is messed up. For cyclothymia, there would be no periods of depression but not major depression, and hypomania. So depression and mania but not major. So not major depression and not mania. It's minor depression, and I don't know if it's minor, but it's just depression that's not major, and hypomania. And it needs to last for at least 2 years. There's something else that needs to last for 2 years. It's dysthymia, but this one would be persistent depression. So chronic depression with never having a manic or hypomanic episode for 2 years. That would be dysthymia. And the major depressive disorder is unipolar. So they would alternate between normal mood and depressive episodes. It needs to last at least 2 weeks. There's also a type that happens in winter, seasonal. There's also a type that happens after birth, postpartum. Now, how to differentiate between hypomania and mania? It's the duration. Hypomania is less than 7 days, and then the psychotic symptoms would only be present in mania. A helpful differentiating between bipolar and unipolar depression is excessive daytime sleepiness, weight instability, early age of onset, abrupt onset, frequent shorter episodes, family history of bipolar, and lower incidence of somatic symptoms in bipolar disease. The management is to stop the antidepressant, and the first line would be lithium or an antipsychotic. The second line would be valproate. We said to never start valproate in a patient younger than 55 due to the reproductive side effects of valproate. And then ECT if it's refractory. Now, grief reaction. Normal grief reaction may take up to and beyond 12 months, and there are different stages. Denial would be numbness, pseudo-hallucinations, preparing meals for loved ones, focusing on physical objects that remind them of loved ones, and then anger, bargaining, depression, acceptance. There is another model, which is Bowlby's and Park's 4 phases of grief. So stage 1 would be shock or numbness, emotional suppression, and then there would be yearning or pining, longing, pursuit, anger, and guilt, and then there would be confusion, despair, disorganization, and then there would be reorganization, reshaping their world and restoring their ordinary life, or acceptance. Then there are some types of hallucinations: hypnagogic, going to sleep; hypnopompic, on waking. Both of them may occur as part of normal grief reaction. Now, what are the abnormal ones? There are some risk factors: being female, sudden death, problematic relationship, lack of social support. There's either delayed grief or prolonged grief. Delayed grief is that happens when there's at least 2 weeks before the grieving starts. Usually grieving would start once the loss happens, but then if there's a delay, that's delayed grief. Postpartum depression, we diagnose it when the score in the Edinburgh postnatal depression scale is more than 13. There's baby blues. This occurs within a week after birth. And then there's postnatal depression that starts within a month. We treat it with reassurance, support, CBT, and then if it's severe, we give sertraline or paroxetine. Sertraline and paroxetine. Paroxetine has high withdrawal symptoms. They're both secreted in the breast milk, but they're not harmful to the baby. For puerperal psychosis, this happens within the first 2 to 3 weeks. It will be severe mood swings and hallucinations or disordered perception, and we have to admit to the hospital in a mother and baby unit. Electroconvulsive therapy is used when there's severe life-threatening depression that's refractory to medication. It's only contraindicated in high intracranial pressure. And also, if there's a recent stroke, we have to wait at least 3 months. Um, some side effects are headache, nausea, memory impairment, memory loss prior to the electroconvulsive therapy, and cardiac arrhythmia. Now, anxiety disorders. My OCD just cannot. Yeah. Oh, I don't like this. Okay. Now it's better. Anxiety disorders. So, generalized anxiety disorder, central feature of anxiety is. I don't think this is that important. There's some physical causes of anxiety like hyperthyroidism, cardiac disease. There's some medications that cause anxiety like salbutamol, theophylline, corticosteroids, antidepressants, and caffeine. Always look for a potential physical cause when considering any psychiatric diagnosis. The DSM-5 criteria for generalized anxiety is excessive anxiety and worry for at least 6 months, difficult to control it, and it's associated with at least three: restlessness, fatigue, difficulty concentrating, irritability, muscle tension, sleep disturbance. Management is with education, low intensity psychological intervention, like individual non facilitated self help or guided self help, and then high intensity psychological interventions would be um, the third stage, like CBT or applied relaxation, and then drug treatment. The first line drug would be sertraline. The second would be any other SSRI or SNRI, and the third would be pregabalin. There's a differential diagnosis which is hyperventilation syndrome. There's a questionnaire called Nijmegen questionnaire that has 16 different symptoms, and if the score is more than 23, that's diagnostic. OCD, obsession is an unwanted intrusive thought. Compulsion is a repetitive behavior. The peak age is 10 to 20 years. It also happens in pregnancy. Oh, these are the risk factors. Family history. Okay. The Yale-Brown OCD scale classifies OCD to mild, moderate, severe. Severe is when the patient spends more than 3 hours a day on their obsession, and it has severe interference, and there's very little control or resistance. And that's the same. The treatment would be okay. Let's go from mild to moderate to severe. Mild would be CBT, including exposure and response prevention. The second line would be an SSRI or more intensive CBT ERP. For moderate, we start with drugs. So we start with SSRI or intensive CBT ERP, and we can consider clomipramine. For severe, we refer to secondary care, so we can't deal with this in the primary care. Compared to depression, the SSRI that we give in OCD would require a higher dose and longer duration of treatment for a response to occur. Panic, abnormal discharge from the locus ceruleus in the midbrain. We treat it with CBT or drugs, SSRI and venlafaxine. If no response after 12 weeks, we go to imipramine or clomipramine, and acute management, we can give benzodiazepines to help the patient relax. For PTSD, it's exposure to trauma plus 4 criteria plus present for at least 3 months. 1 month. Exposure to trauma plus 4 criteria, which is intrusions, avoidance, changes in cognition or mood, and arousal and reactivity. Present for at least 1 month. If the symptoms have been present for at least 1 month, we do trauma-focused CBT or eye movement desensitization and reprocessing therapy. The second line would be venlafaxine or sertraline. Drug treatment for PTSD is not routine. For severe cases we can use risperidone. Debriefing is not recommended after a traumatic event. If the symptoms last less than 1 month, that's not called PTSD just yet. That's just an acute stress disorder or reaction, and it would be treated with trauma-focused CBT. Now, specific phobias are persistent, intense fears. Social phobia, also at least 6 months. Specific phobias, at least 6 months. Agoraphobias, it's not fear of leaving the house, it's fear of being in situations that are perceived as difficult to escape from. So using public transportation, open space, enclosed space, standing in line, being outside of the home alone. Eating disorder. Anorexia would be a BMI of less than 18.5 plus an intense fear of gaining weight plus a distorted body image plus an inability of the patient to recognize the seriousness. There's two types. It's more common in females. Most things are low except the G's and C's. So growth hormone, cortisol, um, glucose, salivary glands are enlarged, cholesterol, keratin. Zinc deficiency is common, and the sit up, squat, and stand test is used to test for muscle function in anorexia. The best marker of clinical improvement is weight gain, and we treat with CBT nutritional support or olanzapine. Bulimia is binge eating at least once a week for 3 months. The patient would be normal or overweight. There would be parotid hypertrophy and teeth erosion. The treatment would be bulimia, focused guided self help for 4 weeks. And then the second line would be eating disorder, focused CBT, and then high dose fluoxetine. Body dysmorphia, it responds to SSRIs but not neuroleptics. Pramac principles is a reinforcement hierarchy. When a patient's less preferred behavior can be treated by using a desired reward. And it can be used in patients with eating disorders. Schizophrenia. Can I see what's left? The strongest risk factor would be family history. Monozygotic twins have a 50% risk of schizophrenia, 10% for to 15% for parents, 10% for siblings, and 1% for if there are no relatives. So the strongest risk factor is family history. Other risk factors: Black Caribbean ethnicity, migration, urban environment, cannabis use, temporal lobe epilepsy. Poor prognosis, strong family history, low IQ. Interesting. Gradual onset, prodromal phase, lack of precipitant, lack of effective component, underlying organic disorder. What are the Schneider's first rank symptoms? Auditory hallucinations, third person hallucinations, thought echo, or voices commenting on the patient's behavior. Thought disorders, insertion, withdrawal, or broadcasting. Positivity phenomenon is delusion is what? Sorry, I didn't even speak to you. I don't care. Okay. Believe that external forces are controlling your body movements, your feelings and emotions, your impulses or behaviors. This is delusion of control. And then delusion of perception is a two-stage process. So there's a normal perception, but it's giving a delusional meaning. For example, seeing a traffic light turn red and believing it confirms they are the Messiah. Okay. Other features: impaired insight. Because there are types of hallucinations that occur, but there would be preserved insight, like Charles Bonnet syndrome. But in schizophrenia, the insight is impaired, so they don't know that these hallucinations are not real. This is very scary. Like, I don't know what... Oh. Okay, schizophrenia is very scary. Negative symptoms like incongruity, blunting of affect, anhedonia, alogia, avolition. There was... Okay. Concrete thinking, neologism, and catatonia. First line is oral, atypical, antipsychotic, and CBT. Pay attention to cardiovascular risk factor modification due to the high rates of cardiovascular disease in schizophrenic patients, which is linked to the antipsychotic medications and smoking. Okay, so I guess we have to think about cardiovascular risk assessment if we have a schizophrenic patient, because it's relatively common. Personality disorders are really... I'm just going to read this because I have to, but I don't know if it's important. There are 3 clusters: weird, wild, worried. 150 is good. So, the weird have an association with schizophrenia. There's a schizoid, paranoid, and schizotypal. Paranoid... Can we order them meaningfully? Okay, so paranoid is accusatory. He assumes others will disappoint, manipulate. He's generally distrustful and suspicious, reacts severely if they are being lied to or slighted. They ensure loyalty of family and friends. So this is paranoid. accusatory. And there's schizoid who's aloof. He or she avoids social interaction. They're not interested in anything. They find physical contact less pleasurable. They're less likely to seek physical contact. They have a flat affect, emotional blunting. They don't show positive or negative emotion, and they're isolated. It's distinct from paranoia and social anxiety. These people are not interested. It's not that they're scared of anything, or they're worried about anything, or anxious about anything. They're not interested. Schizotypal are weird or awkward people. So they have ideas of reference. Everything would be related to destiny. They're in tune with events around me. They have overconfidence, socially inappropriate and self-centered speech, magical thinking, believe random events are linked. Schizotypal. Now, wild, these are associated with mood disorders and substance abuse disorder. So we have the antisocial. Antisocial is, they would have a history of conduct disorder in their younger ages. They have disregard for social norms. They have little empathy. They have poor impulse control. They're willing to hurt others if it helps them. They're aggressive. They don't follow the law. They're overrepresented in prisons, and they have high rates of substance abuse. And they're charming, and they use their charm to manipulate others for personal gain, and they don't show guilt. So these are antisocial people. Borderline people have intense joy and rage, like unstable moods. They switch very quickly between intense joy and rage. So they have stable instability. They have intense, sometimes wonderful relationships that become dramatic and sour over time. They're terrified of abandonment, so they might do extreme things. And they have a defense mechanism called splitting, in which they believe things are either good or bad. Important things, they can either be good or bad. Now there's histrionic and narcissistic. Histrionic is an attention-seeking, excessive emotional. They manipulate others and draw attention. They have superficial relationship. They're viewed as shallow, egocentric. Okay. Now, narcissistic, they come across as pretentious, self-centered. They lack empathy to others' feelings. They have a fragile self-esteem, so they're vulnerable to criticism, and they lash out when they feel slighted. Now, there was an important thing, which is how to differentiate between schizoid and schizotypal. So, schizoid, they would be distant. But schizotypal, they would have magical thinking, dystoid, distance. Both of them have few social relationship, but the schizotypal person would have a desire to have a relationship that they just can't maintain. But the schizoid, they simply don't care. They don't want to have a relationship. Now let's go to the worried group. So we have avoidant or cowardly. So these are shy, timid, socially inhibited people with low self-esteem who believe they're incapable, inadequate, and undesirable. They're hypersensitive to rejection, which makes them even more withdrawn. They want close relationship, but they rarely take social risks. This is an avoidant personality disorder. These disorders are linked with anxiety. Okay, obsessive compulsive is just perfectionist, obsessed with having control, detail, schedule, inflexible, easily stressed, rigid with beliefs and moral issues. Surprisingly inefficient because they spend extra time planning and worrying. Now, dependent is clingy. They intensely fear separation or rejection. They lack self-confidence. They have difficulty making decisions. Okay, how to differentiate between OCD and obsessive compulsive disorder? The difference would be that obsessive compulsive disorder is ego dystonic. They wish they could stop, but obsessive compulsive personality are ego syntonic. So they're happy with how they are, and they don't want to change. Oh, that was a marathon. Okay, there are some overlap in diagnosis. So borderline can be like similar to schizotypal. Really? Maybe. And schizotypal can be also similar to paranoid. Yeah, makes sense. And paranoid with avoidant, and dependent with avoidant, and also clusters A and B. Borderline can be associated with antisocial, or schizotypal, or avoidant. Okay. Now, the new ICD introduced a new dimensional model that allows more flexible diagnosis. I don't know why I studied personality disorders so deeply. I think I just want to move on. Negative affectivity is the tendency for a person to experience negative emotions. Detachment is avoidance of social interactions. Dissociality is disregard for the rights and feelings of other and lack of empathy. Disinhibition is impulsiveness, risk-taking behavior. Anancastia? What? Anancastia is preoccupation with orderliness, and perfectionism. Ooh, 56 seconds. I don't think I can finish in time. Not now. Borderline, pattern, unstable, additional qualifier for those. Okay, what is this? It's just making me go crazy. Personality domain characterized by extreme perfectionism, rigid control, similar to OCPD in the DSM-5. Rigid perfectionism. Okay. Now substance, alcohol. Alcohol advised to be less than 14 units a week. Alcohol is a common cause of hypoglycemia. Why? Because it increases first phase insulin secretion. It affects the pancreatic microcirculation and causes redistribution of pancreatic blood flow into the endocrine parts. So more blood flow goes to the beta cells, so the beta cells work more and they release more insulin. And this leads to hypoglycemia. It also leads to other electrolyte abnormalities, hypomagnesemia. This is the most common one. It's caused by the malnutrition and the alcohol-related diuresis. And it would lead to transient hypoparathyroidism, which would cause even further hypomagnesemia and hypocalcemia. The second most common electrolyte abnormality in alcohol is hypophosphatemia and then also hyperuricemia. So there are three hypos: glycemia, magnesemia, and phosphatemia. How to treat? Well, if the diet is deficient in thiamine, you give them nutritional support with oral thiamine. And then if the patient's in acute withdrawal, you give benzodiazepine. If the patient has cravings, you give naltrexone. To help the patient with dependence, you can give disulfiram or antabuse, which causes a severe reaction with alcohol. However, it's contraindicated in ischemic heart disease and psychosis. And if the patient wants to promote abstinence, you give them acamprosate, which is a weak NMDA antagonist, and it reduces cravings. Well, naltrexone also reduces cravings. Okay. The most common cause of paranoid psychosis with visual hallucination is alcohol withdrawal. When the person consumes alcohol chronically, this enhances the GABA-mediated inhibition in the CNS, similar to benzodiazepines, and inhibits the NMDA glutamate receptors. So when you withdraw alcohol, there would be decreased inhibitory GABA and increased NMDA glutamate transmission. So they would have excitatory symptoms. 6 to 12 hours would be minor withdrawal, tremors, sweating, tachycardia, anxiety. This is when you would give them benzodiazepines. Alcoholic hallucinosis within 24 hours, visual or tactile hallucinations, but not tremens yet. Withdrawal seizures happens after 36 hours, generalized tonic-clonic seizures, and then delirium tremens happens within 2 to 3 days, coarse tremor, confusion, delusion, hallucinations, fever, tachycardia. These symptoms will resolve by 3 weeks if the patient continues to abstain. How to manage withdrawal? Long-acting benzodiazepines like chlordiazepoxide or diazepam. If the patient has liver impairment, you can give them lorazepam. Also, carbamazepine and phenytoin. But these are not as effective in withdrawal seizures. So just benzodiazepines. Now, there are two syndromes, Wernicke's encephalopathy and Korsakoff syndrome. There are some causes of thiamine deficiency. The most common one is alcoholism, and this thiamine deficiency is what causes the damage and hemorrhage to the mammillary bodies in the hypothalamus and the medial thalamus and ventricle walls, and it will cause Wernicke's triad. But there are other causes that could also lead to Wernicke's encephalopathy, like persistent vomiting, anorexia, stomach cancer, and dietary deficiency. Wernicke's triad is coat rack. So coat, confusion, ophthalmoplegia, ataxia. This is thiamine deficiency. Rack, so retrograde, anterograde, amnesia, and confabulation is Korsakoff syndrome. So again, to remember the Wernicke's triad, we have encephalopathy, so confusion, disorientation, indifference, and inattentiveness. Ophthalmoplegia or nystagmus, lateral rectus palsy or conjugate gaze palsy, and then ataxia. When we do investigations, we would find decreased red cell transketolase. It's a thiamine-dependent enzyme in the RBCs that's crucial for the pentose phosphate pathway. It's a biomarker for assessing thiamine deficiency. If there is reduced activity, this means there is reduced vitamin B1, which is thiamine. We can also do an MRI. And the treatment is urgent replacement of thiamine. Now for opioid dependence, naltrexone is an adjustant and started after an opioid period. Okay. No, I don't know if I'm interested in reading this part, honestly. Psychodynamic psychotherapy addressing unconscious defense mechanisms from early life experiences and repetitive maladaptive pattern. CBT, dialectical behavior therapy for impulsive or self-destructive behavior. It's used in borderline. Okay. Psychogenic aphonia is a form of conversion disorder. Someone suddenly loses their voice. Charles Bonnet syndrome has recurrent complex hallucinations, but it's because of visual impairment. Most commonly, age-related macular degeneration, glaucoma, and cataract. Treatment is reassurance. Steroid-induced psychosis. It's a substance medication-induced psychotic disorder. Covate syndrome is sympathetic pregnancy when the expectant fathers experience physical and psychological symptoms similar to their the pregnant partners. Sleep paralysis is transient paralysis of skeletal muscle when waking. We give clonazepam if they're troublesome. Now, Decloram-Ball syndrome, erotomania, paranoid delusion of an amorous quality. Capgras syndrome is when a patient has a delusion that someone they know is replaced by an imposter. Othello syndrome is pathological jealousy. Cotard syndrome is a person who believes that a part of their body or they themselves are either dead or non-existent. Ekbom is a parasite infestation. De Frigoli, they believe that multiple people are the same person. Somatization is when there are multiple physical symptoms that are present for at least 2 years. Illness anxiety is the patient has a persistent belief that they have a serious disease. Dissociative disorder is when they separate certain memories from normal consciousness. They involve psychiatric symptoms. Sorry, what? What is dissociative disorder? I don't know what is this. This is so weird. Explain, please. Hello? What's wrong with you? Okay. Functional neurological disorder. Factitious. Malingering. Okay. What does dissociation mean? It's a defense mechanism triggered by overwhelming psychological stress or trauma. They involve psychiatric symptoms. Cannot remember their own wedding, cannot remember their children. Wow. Multiple personality disorder. Fragmentation of identity. Ugh. This is so hard. Okay. Scales. Depression, hospital, anxiety, and depression scale, PHQ. This is easy. Okay, disease and management. Oh, I'm gonna like cover these and then I'm going to say them. Okay, let me start from here. Sleep paralysis. I believe if this means narcolepsy, I mean I just read this now, so it's clonazepam, but I also want to read this from Neuro. Narcolepsy. Wait. Narcolepsy versus sleep paralysis. Narcolepsy is a disorder. It's a neurological disorder. Sleep paralysis is the brain's active, but the patient has cannot move. What's the difference in treatment? Use UK guidelines. Sleep hygiene, anxiety management, but narcolepsy is a chronic condition and it needs stimulants and oxybate. Type. Back to psych. Schizophrenia. Schizophrenia would be oral atypical antipsychotics. PTSD would be PTSD. It would be EDMR, eye desensitization something something. And then for drugs, I think we give. I want to say SSRI just because. Okay, no. Wait, why not? It's EMDR therapy and trauma focused CBT, but do we not give drugs? Yeah, we give venlafaxine or SSRI, but it's not routine. Next. Panic. So in panic disorder, I believe there's also CBT and SSRI. So sertraline, maybe? No. SSRI and venlafaxine, and then imipramine or clomipramine. And if it's an acute state of like a panic attack, we can give benzodiazepine. Now for OCD, we give SSRIs, but I think for longer duration and SSRI is second line, clomipramine is third line, and then the first line is ERP. I forgot what this was. ERP. Exposure and response prevention therapy. Okay, anxiety would be sertraline. Postpartum problems would be also sertraline, and paroxetine if it's severe. Bipolar would be lithium or an antipsychotic. As a first line, second line would be sodium valproate. And if it's an acute mania, it would be benzodiazepines. Depression is SSRI, citalopram or something. Okay, I'm done. Bye.